Welcome and hello, everyone. My name is Donna. I am the founder and CEO of the Global Liver Institute, and I have the distinct honor of being your host today for this virtual liver cancer summit with our very special guests from the Centers for Disease Control and Prevention for the United States. This has been an incredible month of recognition of liver disease, liver health, and liver cancer as we celebrated as October is for livers. And as a very important part of this, we wanted to shine a spotlight on the incredible work that the CDC has been doing all along for many years behind the scenes in the background, both in their headquarters in Atlanta and across the United States on behalf of liver patients, liver cancer patients, and other patients with health conditions that you may not recognize or have known are connected so closely to liver health. We'll get to talk about that today. We also would be remiss if we didn't have a special thank you for everyone working within CDC on our behalf during this COVID-19 pandemic. So thank you to everyone listening from CDC, as well as our panelists, who I will introduce right now. We have with us Dr. Behnoosh Momin, who is a health scientist in the Division of Cancer Prevention and Control's Comprehensive Cancer Control Branch. We have Dr. Alyson Goodman, and as you can see, she's part of the U.S. Public Health Service Corps, and she is a medical epidemiologist and a lead of the Obesity Prevention and Control Branch Population Healthcare Unit. We also have with us Dr. Giuseppina Imperatore, who is an epidemiologist and statistics branch chief. I love when women are chiefs of things, of the Division of Diabetes Translation, also at CDC. And so just to give some context to this before we start, liver cancer, unfortunately, is one of the few cancers that have been rising instead of falling. We've seen threefold increases over the past few decades, and yet 70% of liver cancers, particularly hepatocellular carcinoma, can be prevented in a variety of ways that we'll discuss during this next hour. Liver cancer, even though there are so many new wonderful treatments on the market and so many excellent cancer centers, academic centers and community cancer centers around this country, the survival rate is only, the 5-year survival rate is only 18%. And it's for that reason that the Global Liver Institute has created our Liver Cancers Council and has asked everybody to sign on to a pledge to double that survival rate in the next 5 years, and has conducted all of our October is for Livers campaign that we hope you will look at our website, globalliver.org, and participate in over the course of the remainder of this month. But today we have an opportunity to talk with these fabulous experts in CDC and the role that they play in combating liver cancer from so many different directions and approaches. And I will start with you, Dr. Momin.
Sure, Donna, thank you for the invitation to speak on such a critical topic during a very important month, Liver Cancer Awareness Month. It's a pleasure to be here. CDC's Division of Cancer Prevention is advancing cancer prevention nationwide for everyone. The work includes developing innovative approaches to promote cancer prevention, screening and early detection, as well as research and evidence-based programs. Now, with respect to programs, since 1998, CDC's National Comprehensive Cancer Control Program has provided funding, guidance, and technical assistance so that programs can design and implement impactful and strategic, sustainable cancer plans to prevent cancer. Now, The program currently supports all 50 states, the District of Columbia, as well as 7 US Pacific Island and jurisdictions and territories, as well as 8 tribes and tribal organizations. Since its inception, since 1998, more than 98,000 people have been engaged and involved in cancer coalitions. And Donna, cancer coalitions are, they serve as the backbone to our programs. And we have 69 plans, cancer plans, that have been created and updated. Now, the key priority areas for the National Comprehensive Cancer Control Program is one, is in primary prevention, 2, early detection and screening, and then 3, survivorship. But we also have 3 cross-cutting priorities, and those are policy, system, and environmental approaches, 2, achieving health equity, and then 3, outcomes through evaluation. So that way we are able to take the lessons learned and best practices and adopt it through our other programs. Now, Donna, as you mentioned, my role is to provide the scientific support to these programs as they develop their cancer plans, their strategies, and they provide interventions to prevent liver cancer. However, in addition, I'd like to also mention that I also lead what we call research demonstration projects, which include recruitment of these programs to put the evidence-based interventions, or what we call promising practices, into action. And I can talk about that a little bit more. But before that, I'd also like to mention at the national level, we have the National Comprehensive Cancer Control Partnership. CDC is one of 19 national partners whose purpose is to support the comprehensive cancer control coalitions in the states, the tribes, the territories, and the US Pacific Island jurisdictions, as I mentioned. And I'm excited to share that we have now established a working group called the Vaccine Preventable Cancer Work Group, which I co-lead and incorporates hepatitis B virus infection, which is a key risk factor for liver cancer. So Donna, I think we're moving in the right direction in addressing and combating this disease.
Thank you so much for that. And I agree that, or I want to underscore your point about vaccines and its role in liver cancer prevention. You know, if for so long we've said, well, only if there was a vaccine that can prevent cancer. Well, you know, we do to a degree where if people had their hepatitis B vaccines, and I know there are various aspects to that campaign, whether it's, you know, birth dose vaccination or, you know, catching up for those who maybe in some generations that might have, you know, missed the hepatitis B vaccination. Certainly as a patient who has gone on infusions and immunological therapies for my IBD, I had to be, you know, screened for hepatitis B and made sure I was vaccinated before we started those therapies. So there are so many approaches, but a hepatitis B vaccine is a great success story that's little talked about, and it has a huge role in being able to prevent liver cancer. So I'm excited to hear more about that initiative. At this point, we want to talk a bit with Dr. Goodman, and I think you also have some slides to share with us to illustrate the work that you do.
Thank you so much, and thank you very much for the opportunity to speak today. I'm Commander Goodman. I work in the Division of Nutrition, Physical Activity, and Obesity at CDC, and really pleased to be able to provide some context for the relationship of nutrition, physical activity, and obesity to liver disease and ultimately to liver cancer as well. Next slide, please. So the vision of our group, right, is to create a world where regular physical activity and good nutrition, as well as healthy weight, are a part of everybody's life. Every American deserves equal access, you know, to these things. And our mission is to lead strategic public health efforts to prevent and control obesity and chronic disease nutrition, other health conditions through, that would be including liver disease, right, through regular physical activity and good nutrition. Next slide, please. So our strategic priorities really aim at working throughout the lifespan. So that's a healthy start for infants, helping children and youth to grow up strong and healthy, and to help adults and older adults to maintain a healthy lifestyle or help to manage nutrition, physical activity, and healthy weight, or trying to achieve a healthy weight over time. Next slide, please. So as many of you are well aware, obesity is an epidemic, really a pandemic in the US and worldwide. And the prevalence of obesity among US youth, that would be aged 2 to 19 years, has increased dramatically over time. So we've had more than a tripling since the 1970s. But this slide illustrates changes since even the end of the 1990s up to 2015 to 2016. We recently got data for 2017 to 18, and again, we see rises in each of these population groups. Prevalence is the highest among adolescents aged 12 to 19, and then followed by 6 to 11-year-olds and 2 to 5-year-olds. And it's those 2 to 5-year-olds, right, that really tug at your heart. And 13.9% is high, and unfortunately, that number is continuing to grow. We have 14 million youth in the U.S. living with obesity. That's nearly 1 in 5 children. Next slide, please. So what's the connection between obesity and liver disease, liver cancer, the trends and directions? So NAFLD is currently the most common liver disease, as you on the call likely know very well, which is estimated to affect 33% of adults worldwide and can progress to hepatitis, fibrosis, cirrhosis, and hepatocellular carcinoma. So just to again put things in context, in 2017-18, we've got the prevalence of obesity, among adults, nearly half of US adults, and severe obesity, 9.2% among adults aged 20 and older. And I already told you about children, but the risk factors for NAFLD and NASH, obesity puts individuals at a dramatically increased risk of developing non-alcoholic fatty liver disease. And people with NAFLD are more likely to have NASH if they have obesity, especially when that adiposity is more central to the body, so that kind of pear-shaped with a large waist size. But one of the key messages I really want to make sure that we're talking about and focusing on today is that obesity prevention and treatment is also NAFLD prevention and treatment. Next slide, please. So having obesity during childhood increases immediate and future health risks for children. It has been causally linked with 13 types of cancer, including liver cancer, and also, of course, the fatty liver disease, as I mentioned a moment ago. Next slide, please. So just wanted to give a little bit of context about our funded program recipients. Our current initiatives that impact, prevention and treatment of obesity, we really see as hopefully preventing and treating liver disease and liver cancer. And since no medication is currently available, solely to reduce NAFLD or NASH, again, treating that obesity is the best or one of the ideal ways to prevent and treat NAFLD. And so DMPO has several programs across the country that are working on reducing obesity and improving nutrition and physical activity. So one of those is the State Physical Activity and Nutrition Program, or SPAN. So CDC funds 16 state recipients to implement evidence-based interventions at state and local levels to improve nutrition and physical activity. And you can see those there. Those are the kind of aqua-colored states. We also have the High Obesity Program, where 15 land-grant universities are funded to work with community extension services to increase access to healthier foods, as well as safe and accessible places for physical activity. And the REACH program, which is Racial and Ethnic Approaches to Community Health. It's been around for decades now. And it gives funds to state and local health departments, tribes, universities, and community-based organizations to reduce health disparities among racial and ethnic populations with the highest burden of chronic disease, such as hypertension, heart disease, type 2 diabetes, and obesity. Recipients work through culturally tailored interventions to address preventable risk factors, including tobacco use, poor nutrition, and physical inactivity. Next slide, please. So CDC's child obesity research demonstration projects are another example of what we're doing to really focus in on bringing evidence-based intervention to children and their families. So since 2011, CDC's conducted these what we call CORD projects to support grantees that test and apply the most promising obesity prevention and management strategies and find affordable solutions that can benefit the millions of children that are eligible for the Children's Health Insurance Program, or CHIP. And through these projects, we focus on improving community clinical collaborations to help prevent and manage child obesity among low-income kids. And this research helps to inform our child obesity efforts across the nation. And our research and evaluation efforts across the, where are we at, 9 years of CORD so far, have illustrated really promising reductions in BMI for low-income kids aged 2 to 12, as well as improvements in nutrition and physical activities behaviors. And I'll talk more a little bit about these later. Next slide, please. We also have the COMMIT project. So this is child obesity management with MEND implementation teams. So MEND is a comprehensive family-based program that helps kids aged 7 to 13 who have or are at risk of having obesity to improve their health, fitness, and self-esteem. MEND is a proprietary program that was started globally and then brought to the US. It's a fully packaged program, so it comes with everything you could possibly need to implement it. And they've helped over 100,000 kids and families, and is one of the world's largest healthy lifestyle programs for children. So we've been working with the National Association of Community Health Centers to increase implementation of MEND and similar evidence-based childhood weight management programs in federally qualified health centers. Next slide, please. We also have a program called the Child Obesity Data Initiative, or CODI. CODI aims to leverage existing data in order for us to better understand what's happening to children and their families over time with regard to not just their weight, which is somewhat important, but even more important, right, is the nutrition and physical activity, and trying to understand which interventions are working best for whom, where, how, etc. And so we're looking to understand when obesity screening is occurring and the actions it triggers to address, assess, and compare effectiveness of different interventions in the clinic and community, which dose and characteristics of interventions work. And we just need data to address the gaps in obesity surveillance, quality improvement, and program evaluation. And so the idea is to link longitudinal data that are currently siloed in various organizations together so that we can really better understand patterns over time. And thank you. Look forward to the panel presentation.
Thank you so much. Understanding the obesogenic cancers and the way that obesity drives cancer, and particularly the role and the impact that it's having on our children. And so, predicting out the impact on fatty liver disease, non-alcoholic steatohepatitis, NASH, which is becoming one of the leading causes for transplantations and for cancer diagnoses. These are how all the parts fit together, and why it's so important to have you and your work as part of this panel and this conversation today. So thank you so much. Dr. Imperatore, can you please weigh in on the work that you're doing and how your work in diabetes also links in to this conversation on liver cancer?
Sure. Good afternoon, everybody, and thank you for the opportunity to speak today. Just to give you some statistics about the problem of diabetes in America. 1 in 10 Americans has diabetes. This corresponds about to 34 million people, and about 1.5 million adults are diagnosed with diabetes every year. And diabetes is also the most expensive chronic condition in the nation, with the 327 billion total cost, medical cost for each year. What's more is that 88 million American adults, that is 1 in 3, have pre-diabetes, which is a condition where the blood sugar levels are above normal range, but not high enough to be diagnosed as diabetes. And those living with pre-diabetes, more than 80% of them are unaware of it. So the Division of Diabetes Translation at the CDC is committed to ending the epidemic of diabetes by reducing the number of preventable cases of diabetes and improving the health and quality of life of those living with diabetes. So our division is essentially has 3 branches with distinct but interrelated functions. The epidemiologist statistics branch is the principal scientific research unit within the division and conducts public health surveillance and research that provide the basis for effective public health policy decisions to reduce the burden of diabetes. And then we have the translation, health education, and evaluation branch, which synthesizes and translates a body of best science and practice that can be applied to various public health settings. And then the program implementation branch, which provides programmatic leadership, guidance, and consultation on a range of strategies to improve diabetes prevention and control programs in state, territories, tribes, and communities. The division also works with other federal agencies, state health departments, healthcare providers, and community organizations to identify people with pre-diabetes, because as I said, very few of them know that they have the condition, prevent type 2 diabetes, and prevent the diabetes complications. Of course, in that, improving the health of all people with diabetes. So why diabetes is also a important issue for liver disease, chronic liver disease especially, as we already have heard this morning. Non-alcoholic fatty liver disease is a metabolic liver disease that is closely associated with obesity and type 2 diabetes. We looked at the data in a national representative sample of the U.S. population, and we found that the prevalence of non-alcoholic fatty liver disease, this is assessed by ultrasonography, was greater among persons with diabetes, about 46% prevalence. And in those with the pre-diabetes, this prevalence was 25%, compared to those with the normal glucose, where it was 16%. So definitely diabetes and liver disease may share, some common pathogenetic factors, such as, for example, insulin resistance. On the other hand, there is also evidence that non-alcoholic fatty liver disease increases the risk of diabetes. We have looked now at a very recent meta-analysis. This was just published in August, where in about 500,000 middle-aged individuals from different countries provides the evidence that the non-alcoholic fatty liver disease is associated with a 2-fold increased risk of developing diabetes. And also we know that the mortality for chronic liver disease is increased in people with diabetes as compared to those without diabetes. This may be bidirectional, as I said, underlying fatty liver disease is a risk factor for type 2 diabetes, while diabetes is also associated with an increased risk of cirrhosis, liver cancer, and hepatitis. So given the importance of preventing type 2 diabetes and the evidence from well-conducted randomized clinical trials that structured lifestyle intervention can cut the risk of type 2 diabetes in half. In 2009, Congress authorized the CDC, the Division of Diabetes, to establish the National Diabetes Prevention Program, which is a public-private initiative to offer evidence-based, cost-effective interventions in community across the U.S. to prevent type 2 diabetes. This is essentially this program is funded because we are, in the division of transmission. We are translating what we learned from the clinical trials, specifically for the diabetes prevention program, that if you make realistic behavioral changes, will help people with pre-diabetes lose weight. This is about 5-7% of body weight, and in return reduce the risk of developing type 2 diabetes by 58%. So working with a trained lifestyle coach, this program participants learn to make better and healthier food choices, be more physically active, and find ways also to cope with stress. This program is delivered in person, online, or distance learning, or through a combination of all these formats. So if this is also implemented now nationwide, and it's plausible that our prevention efforts in preventing type 2 diabetes, because of the very strong link between type 2 diabetes and non-alcoholic fatty liver disease, may this in return also reduce the risk of morbidity and mortality for chronic liver disease. Thank you.
Dr. Imperatore, thank you so much. Those are some really important pieces of information, particularly the recognizing the bidirectionality of diabetes and NASH. When I talk to my fellow diabetes patient advocates and ask them, have you heard of NASH? They're like, what are you talking about? There is no recognition. And so the work that you're doing, providing the evidence, the statistics, the data for us to be able to share with them to understand the scope and scale of their risk as type 2 diabetes patients is so important for us to be able to do our work, effectively as advocates. And one of our board members is actually very involved with the DPP, and so it's been exciting to see how that has moved from concept to research to application. And moved into community programs and partnerships and can impact people's lives. I think the question we're asking NASH that you're helping us answer is, what is the applicability of DPP to NASH patients? Is it the same type of interventions that are needed, that worked in diabetes patients, that work for NASH patients, maybe some of those who don't have diabetes? Is it just about the 7 to 10% weight loss, or is there a particular type of weight loss that would be really important to impacting or reversing NASH? And so we look forward to being able to dig deeper into some of those specific questions so that we can give actionable information to NASH patients. So one of the questions we talked briefly, Dr. Momin, in your remarks, you mentioned health equity. So I'd like to circle back around to now just having a conversation about making sure that the work that you're doing across your divisions, across your branches, reach the people who need them most. And so if each of you could take a moment and talk about the health equity aspects of what you're doing, or reinforce points that you made in earlier parts of your presentation.
Sure. Donna, so the Division of Cancer Prevention and Control has been involved in sharing statistics and education on liver cancer. I do want to mention that for liver cancer, CDC has published several reports on liver trends in our weekly CDC morbidity and mortality reports. And I also earlier mentioned we fund these demonstration projects since 2015 in collaboration with the Division of Viral Hepatitis. So I'd like to talk a little bit about that, which I believe will touch on your question. The first project that I led, and it was a 3-year project between 2015 and 2018, included onboarding 2 programs. We had the Cherokee Nation Comprehensive Cancer Control Program, as well as the Idaho Comprehensive Cancer Control Program. And the objective was twofold. One was to implement key interventions in the target population and then evaluate the success of those interventions. And then 2, to develop an action plan for liver cancer prevention that could be adopted to all of our programs. In Cherokee Nation, and I think this is an important program, we work closely with the Cherokee Nation Health Services. This was under the leadership of Dr. George Mira. He's an infectious disease specialist, and as well as Dr. David Gahn, who is the Cherokee Nation Public Health Director. And what we did here, Donna, is we implemented 8 virtual liver cancer didactic sessions into their existing platform called Project ECHO. And for those who are not familiar with Project ECHO, it stands for the Extension for Community Healthcare Outcomes. And so this model utilizes a knowledge sharing approach where the expert shares knowledge and awareness on to the primary care physicians and those healthcare providers in the rural and underserved areas. So Dr. Mira's presentation focused on the knowledge and awareness of the statistics of the role of the liver, risk factors, signs and symptoms, as well as the ability and intent to diagnose. So what I mean here is the ability to identify patients that are at risk, and then the intent to actually speak with these patients about risk, and then recommend screening for those who are considered high risk. Now, we also understand the role of other healthcare providers, so not just primary care physicians, but nurses, nurse practitioners, physician assistants that actually play a key role in a patient's journey to getting adequate health care. And so we therefore added what we call provider education workshops with similar content, and the goal was to share the knowledge that's not exclusive to our primary care physicians, but to all engage all providers that engage with the patient. But I also want to mention, Donna, as we deliver presentations to coalitions, as I mentioned earlier, they're the backbones to our programs on similar content. So prevention, symptoms, the causes, and the diagnoses. And at that time, we had 26 coalitions in Cherokee Nation. And these included workers from the public school system, from local recreational centers, from farmers markets, as well as other organizations. And the reason why I bring this to your attention is it's important for communities to be aware of the disease and the risks, right? Not just the patient, well, once you've been diagnosed, and the healthcare provider, but for prevention to really, really work, we have to engage and educate communities about the risks associated with this disease. So we conducted retrospective pre-post surveys. I don't want to go too much into the data because it's been published in Preventing Chronic Disease, the journal. But overall, what we saw here was that there are these improvements across the interventions in all 4 areas of knowledge, awareness, the ability, and intention. So these were really our measures of success for us, which will help us develop these best practices and lessons learned for all of our other programs. And I'll also quickly mention that while we're working with Cherokee Nation, we were simultaneously engaged in some of the work with Idaho. And we took a completely different approach here. So Idaho was experiencing a decline in hepatitis B virus vaccination rates among babies at birth. And Donna, you talked a little bit about this earlier. And so they were interested in developing a social media education campaign and with the creation of various marketing materials, infographics, social media graphics, as well as incorporating education around this relationship between HBV and liver cancer in their healthcare provider workshops that were taking place across the state. And so we understood what the problem was, and we were trying to then develop innovative solutions to again, address this issue. We're in the process of publishing these findings, but this really helps. I just wanted to provide a background on how they're utilizing a different approach to reach their target audience, which in this case were mothers, hoping to shine light on the importance of vaccination. So you can see, Donna, just a couple examples of how we go into those high-risk populations and really focus on developing interventions to help support and prevent the disease.
I really appreciate that, and I appreciate you, recognizing our friends in the viral hepatitis division. We certainly invited them to be part of this conversation and recognize that they're so busy, but wanted to make sure that everyone knew that we valued and do value the work that they do every day, and the impact surely that having a cure for hepatitis C. I remember when I actually saw that word on an FDA approved slide in a presentation, and the impact that had, and I recognize from the work of now Nobel Prize winning Harvey Alter at NIH to the work done at FDA rigorously to approve things through their process, through the work of John Ward and folks at the viral hepatitis division. All these parts work together to be able to have the impact that hepatitis C medications and therapies have had and continue to have on liver patients who suffered for so long. So glad that you mentioned our colleagues, your colleagues, our friends and allies in the viral hepatitis division. So it's so important. Dr. Goodman, you talked about equity and reaching out to communities, and specifically Project Reach in your presentation. But we know that these past few months, going through this pandemic has been particularly hard on communities of color. You recognize the specific impact on patients with liver disease as a risk factor in your CDC guidelines, which we've pointed people to on our websites. But can you give us more information on the work that you've been doing in COVID that impacts us?
Absolutely. Just real quick about health equity and how we weave that into our work. Yes, we do have Project Reach, as you've already mentioned, that I described earlier. I think a very important point to remember is that obesity prevalence varies very significantly by race and ethnicity, by socioeconomic status, and by a number of other factors. And so we have to very carefully consider those disparities in how we approach working on nutrition and physical activity, for example. So in our core activities where I'm in kitchen, we focus on helping low-income children and their families. We have to work with people where they're at, and life right now with COVID is very difficult. We're it's an entirely a different landscape for individuals. So that's been really interesting work in adapting those research studies for COVID, but also as it relates to our Commit project, where we're helping to implement evidence-based interventions in health centers and in community sites. The other quick thing I wanted to mention was that given those differences in prevalence, we're really concerned about what differences in NAFLD prevalence might be in children. In a recent analysis that we presented a couple of weeks ago at the American Academy of Pediatrics meeting and at Academy Health this year, we found, using a really large electronic health record data set, that children with overweight and obesity, no surprise here, had a higher prevalence of NAFLD than children with a healthy weight. But that our results suggested that many at-risk children are not being screened for NAFLD, which is a real focus of our work in quality improvement and helping to make sure that children are appropriately screened for co-occurring conditions like NAFLD. And if you don't screen for it, you don't know it's there. But surprisingly, in this data set, about half of children with obesity that we identified appeared to have NAFLD based on screening ALTs. So that's half. That's significantly more than has been documented in recent literature. So we're writing a manuscript on that now, and hopefully we can get that out soon. Regarding COVID, so I have participated in the COVID response since March of this year. Response work is extremely hectic, and COVID is no exception. in my role in March to May of this year, I was the team lead for the underlying medical conditions group within the Community Interventions and Clinical Populations Task Force. And we drafted the initial list of conditions that might increase risk for severe COVID-19. At that time, we had almost no published evidence to base that list on. It was very difficult. We were hearing a lot of, anecdotal evidence, and we had a few published studies from China, a little bit trickling out of Europe. And so we had to base that list on knowledge from influenza, other similar viruses, et cetera. And so it really was evidence from those other conditions that allowed us to include liver disease on that initial list. Since then, limited evidence from meta-analyses and cohort studies about US patients with severe COVID has indicated a potential independent risk, right, or association of liver disease and severe illness. But further studies are needed in this area, so I'm just going to put out that call. And in May of 2020, our group was able to collaborate with the Division of Viral Hepatitis, which keeps coming up, on a webpage specifically about COVID-19 and liver disease. And we really prioritize communicating to patients and the public about the potential risk associated with COVID-19 and liver disease. And that page continues to get updated as a priority communications page. So COVID has really introduced, new complexities to liver disease and obesity. Having obesity increases the risk of severe illness from COVID-19. Having obesity also might triple the risk of hospitalization due to a COVID-19 infection. And similarly, we see that, individuals with liver disease might be at this higher risk for severe illness. And we also know that patients hospitalized with COVID-19 have increased liver enzymes, often ALT, AST, indicating some amount of liver damage. So because of the connections between obesity and COVID outcomes, there's a lot of overlap in my response work and in my daily job. And it's been a really unique opportunity to bring this experience to a CDC response. So, thank you.
So grateful for it. We have and continue to receive so many questions from patients about trying to personalize what their risk is of contracting COVID, of having severe outcomes from COVID. And your data, your information, and the rapid evolution of it has really been what we've relied on to inform those patients, and myself being one of those patients. I thank you for it. I think the conversations that we've been having with patients, moving forward is to, make sure that you're not, gaining too much weight in your home, and, the refrigerator is just 2 steps away. Maybe take 10 steps outside instead of the 2 steps to your refrigerator. Continuing movement and physical activity, really, I think in some ways, being a liver patient, being immunosuppressed, for 26 years now since my transplant has, sort of better prepared me. I had masks, hand sanitizer, washed my hands frequently, kept some distance, even though I did travel and live a full life. But we sort of knew how to construct our homes and our life to be able to do things, safely. So with this additional information, I still go to my, doctor's appointments, get my lab work done, get the test procedures and medications, infusions and things that I need. Now that my physicians have also used your guidance to construct their offices safely and do the hygiene that's necessary to make a safe clinical experience. And so, having really lived and been the beneficiary of all the work that you've put in, I just want to say thank you and assure you that, it is getting to particularly liver patients, transplant recipients, those who are immunosuppressed, through our COVID-19, response program. But, really appreciate the work that's gone into that. So Dr. Imperatori, one of the things that we have struggled with in the 6 years that I've, been at the helm, having founded the Global Liver Institute, is making sure that we were designing approaches to liver health that were data-driven. That in order to do that, we needed to really understand the scope and the scale of the problems in specific liver diseases and liver diseases as a whole, as you've all shown from this conversation today, as how much they overlap and intersect, so that we could address them appropriately. You know, clearly you all, you know, work together. I think it's something that from the outside hasn't been appreciated as much, which is why we wanted to do this today. But, you know, tell us more about how CDC works together sort of across these different divisions and branches on liver health to put together sort of a full data picture, and also how we might improve that in the future.
You know, we at least in the chronic disease center, we work across the divisions all the time. So if you think about, you know, the natural history of type 2 diabetes, for example, we definitely, you know, recognize obesity as one of the strongest risk factors for developing type 2 diabetes. So for, you know, programs that are aiming at reducing obesity in the population, especially also in the youth population, which is, you know, as you heard this morning, a really, you know, big concern. We definitely, you know, collaborate on you know, these programs. For example, the Division of Diabetes Translation in 2000 launched the Search for Diabetes in Youth study, specifically to address the reports that were coming up during the time about the increase of type 2 diabetes in children, definitely, you know, related to the increase in obesity in the country. And this is a study that still today is ongoing. It's almost finished after 20 years. And we did, you know, indeed demonstrate that type 2 diabetes is increasing in children and in adolescents in this country. So definitely programs that will aim at reducing obesity, as our sister, you know, division in the Division of Nutrition and Physical Activity and Obesity is, you know, engaged in, we definitely in return probably reduce also this you know, concerning trend in increase in type 2 diabetes. What I also would like to highlight are a number of also initiatives that think about the reducing disparities. For example, the National Diabetes Prevention Program is now, we have recently funded 10 national organizations that will start new in-person programs in underserved areas, specifically to address, you know, the problem of fewer resources and health disparities in these underserved areas. We also have a program, it's called the Appalachian Diabetes Control and Translation Project. This is you know, a project that is focusing in the Appalachian region, that is a region of very high risk of type 2 diabetes. This is another, you know, a program that is addressing health disparities in diabetes. And we also have the Native Diabetes Wellness Program that is trying to, you know, balance between cultural practices and Western science in India country to promote health and help prevent type 2 diabetes among Native Americans who, as you know, are also a high risk of type 2 diabetes.
I think that's fantastic. And I really appreciate that as part of this conversation, we have really honed in on different types of disparities or different places where we need to have equity conversation, whether it's in tribal communities or in Appalachian communities. My mother's family is from West Virginia, so that resonates very much with me. Or Project Echo and how it it brings multidisciplinary care to all different types of communities, bringing expertise across different practices. Recognize there can be disparities in cities. We talk in Washington, D.C., looking at health disparities, overlaid to the Metro map. And so we see disparities in liver disease and in liver cancer in wards 7 and 8 that we don't see in wards 2 and 3, for example. So I love that we've really had a really broad lens and a broad definition as we look to applying this work. So, over the course of this conversation, as we start to bring it to a close, I just want to emphasize, why we wanted to have this conversation and why we wanted to structure it this way. GLI took on liver cancer and created a Liver Cancers Council as one of its central pillars as a way to serve the entire liver community, because we know that any type of liver disease, if left unfettered, unfortunately can develop into liver cancer. And so whether it's hepatitis B and drawing attention to hepatitis B vaccines or hepatitis C cures, or reduction of obesity to prevent NASH, and screening for all of these diseases, as well as screening for NASH, and addressing type 2 diabetes and the special risks for fatty liver disease and liver cancer that brings, that we could serve the entire swath of liver patients and really be in the position of promoting liver health. And so I'll just maybe ask you as a sort of a final rounding question, and maybe I'll reverse the order and start with Dr. Imperatori. If from your perspective, your lens, your branch, your work, your vision of this field, if you could do one thing to most impact liver health, what would that be?
Well, I lead the epidemiology and statistics branch, so I'm always for good data to make, to inform any health policies. So I think what we need probably is better understanding of the burden of, I'm referring specifically to non-alcoholic fatty liver disease. As you know, there are currently there are no accepted standard definitions for non-alcoholic fatty liver disease in epidemiological studies. And so therefore the estimates are all over, vary very widely, even using the same data. For example, it's believed that non-alcoholic fatty liver disease is the most common, probably chronic liver disease in the United States. And the estimates will go from, as little as 5% to 31% in the general population, depending on the diagnostic method that is used. Of course, we know that, the gold standard is, for diagnosing non-alcoholic fatty liver disease is a liver biopsy, but of course, liver biopsies are not typically feasible in population-based epidemiological study. So therefore, diagnosis is usually made using surrogate markers such as, radiologic imaging with ultrasonography, liver enzymes, and fatty liver index. And for example, the fatty liver index was even developed in an Italian population. I don't know, how this index is, specific and sensitive enough in a multi-racial population like the United States. So I think probably the development and validation of a non-invasive measure of fatty liver disease will be probably good in providing estimates and its trend at the population level. As you know, the basic of epidemiology and public health is you have to know how the disease is distributed in the population in order to make any good programmatic efforts in controlling and preventing it.
I certainly agree with both getting good data and moving to non-invasive diagnostics and getting beyond the biopsy. Dr. Goodman, your one thing that you would love to do to impact liver health?
Just one thing.
One thing, if any, but one thing that you would have us take away.
I'm teasing. So helping to spread and scale evidence-based interventions for the prevention of obesity is really critical, as well as treatment. Of course, treatment in kids is prevention for adults, right, if we can. But ultimately, primary prevention is critical, which can be done in lots of ways, but through policy systems and environmental supports to help people have a healthier lifestyle. But through better uptake of those evidence-based interventions, we hope to be able to reach a lot more children and families. Also, there's really critical quality improvements that can be done in pediatric and adult care. And that includes the way we talk about obesity, using patient-centered language, reducing stigma and bias in the way we talk about weight. And especially in the context of COVID, with food insecurity being at the highest rates we've seen in many decades in this country, focusing on things that are actually doable potentially, or the impacts of nutrition and physical activity in daily life. So taking those steps, sure, it might help somewhat, right, in terms of weight, but it really helps in terms of anxiety, right, which is a major player as it relates to obesity and general systemic inflammation, right, which can be related to liver disease and so on and so forth. Also related to sleep is another really great example where, I think we can really reframe conversations around these issues. And so, sorry, I think I tied together three things into one thing.
That was very skillful. But it does make me want to commit to taking my dogs and myself for a walk after we finish filming this. So get a little outside, get a little movement. Attend to my mental health as well as to my caloric burn. And so, Dr. Momin, we'll let you have the final, well, I'll have the final word, but I'll let you have the final word in terms of how you would most like to impact positively liver health.
I have to say, I know one is tough, but I'd have to say addressing hepatitis C virus infections is critical. But I also just want to quickly add, I also think better ways to address the risk factors and its relationship to liver cancer. I do think we are on the right track. We focus our work on awareness and knowledge, including development of culturally tailored materials, education, and outreach activities on the risk associated with liver cancer. But I also think understanding which interventions, and I spoke about some of this as well, are effective to reduce or reverse the trends. And so I know in the literature, we know improved surveillance systems, vaccination screening, which I've touched on, are critical. I do want to mention improved delivery of viral hepatitis services throughout a patient's journey. So from screening to receiving a positive diagnosis and then hopefully being cured. I think those are all potential areas that could positively impact the patient.
Thank you. I absolutely agree. So better data, better diagnostics, better work, evidence-based interventions with children and families, and making sure that we have the public health infrastructure that makes sure that we not only have these wonderful innovations, but that they truly reach people. I think if we address even half of that I want to do all of it with you, that we will make a big dent in reducing the number of patients and families suffering with liver cancer. And I thank you so much for this conversation today and the work you have done and the work that you will do with us moving forward. So thank you so much.